and Dr. Carver. Today, I'd like to talk about one of our projects, development of e-learning model for gesture insertion. Various technologies such as e-learning and VR or AR and other simulation modalities are now available in medical and surgical education. As we experienced since last year, the demand is now increasing. To develop such a teaching models, it's crucial to understand the theory of instructional design. However, there are a few studies dealing with both instructional design and surgical education. This is a topic that we wanted to integrate into the new e-learning. Gesture insertion is usually performed as a treatment for pleural diseases, such as pneumothorax, pleural effusion, and hemothorax. It's a basic and life-saving procedure that all surgeons and physicians should master. But at the same time, it's high stakes, so that the complication can be critical. You may injure the lung, the heart, and the liver, or you may cause infection. McGill offers hands-on sessions for general residents. However, the instruction is not standardized yet. Then, the aim of this study is to develop an e-learning model for gesture insertion based on the theory of instruction design, and to investigate its feasibility for resident training programs. Today, I just focus on the first one, how we develop the e-learning. To start the project, we consulted with an expert of education technology, Dr. Tamara Carver. I learned to follow these principles: adding model for design, learning objectives, and focusing on learning, not teaching. I will talk about these principles in detail individually. First, I talk about the EDDI system model, which is a systematic approach for curriculum and instruction design. Analyze the gap, design what to deliver, develop the content, implement it in a real-life education, and evaluate the effect. In our project, in the first place, we analyze the gap with the fact that instruction of gesture insertion should be standardized, and surgical residents were chosen as the audience. Second, for design, we worked on a concept map to visualize our idea, what to include. And then we set the learning objectives that I'm showing in the next slide. Then we decided how to assess the learning. Here we employed multiple choice questions for knowledge and the global rating scale for skill assessment. Also, we recognize to assess usability of the e-learning by survey is necessary. In the stage of development, we try to deliver it with multimedia-rich content and make it as much interactive as possible. Decided to use my courses as a platform because all McGill people can access, and used an e-learning authoring software. Here are the learning objectives. As content, we included indication, equipment, procedure, and complications. Then, according to each content, we determine the learning objectives meeting SMART. The learning objectives should be specific, measurable, achievable, realistic, and for appropriate time and target. This is an exciting part to develop multimedia content. We try to attract the audience visually and to deliver the content in a concise format. A video, animations, and graphics are included. Here, a graphic in the middle is about the heart injury as a complication, and the right animation is about how local anesthesia is performed. This is a video showing how the procedure should be done. Two medical students helped us film the video. It demonstrates a step-by-step instruction on the same situation the resident will experience at the hands-on training. I'll be silent because the video has narration. I hope you enjoy it.
Position the patient in either the supine or semi-recumbent position. Identify the site for insertion of the chest tube in the 4th or 5th intercostal space. Use full barrier precautions. Put on a surgical mask, scrub your hands, and wear a sterile gown angle space. Air or fluid may be evacuated by aspirating through the syringe, horizontal or parallel to the upper edge of the rib at the predetermined site. Using a Kelly clamp, dissect the sepals bluntly just above the rib. Once you reach the pleura, push and puncture the pleura with the tip of the clamp. You may hear a popping sound when opening the pleura. Once the tip of the tube has passed through the incision, remove the Kelly clamp and advance the tube into the pleural space to the pre-measured depth.
I wish I could show you all the video, but the time is too tight, so I need to shorten the video. Another thing is to provide the learner-centered learning so that we have to make the e-learning interactive. It should be differentiated from PowerPoint lecture where the learner is usually learning passively. The created module requires learner's active attitude toward the content. For example, we show the information not by bullet points, but show the information when a learner has an action with a mouse. And as a knowledge check, we include different types of quizzes. There's an example of a quiz using a hotspot on the right. Click the appropriate location for chest tube insertion. When you click the fourth or fifth intercostal space between the anterior and the mid-axillary line, you will receive feedback saying you are correct. Also, the assessment of knowledge for baseline and after the learning were also done on my courses. The contents were developed using an authoring software, which is called Articulate 360 Storyline. Now I shared how e-learning will develop looks. As I mentioned earlier, it's on the Medial platform, my courses. I chose the chest tube insertion course, and in a brief introduction, you can see clarify the learning objectives. And on the left side, there are contents. There are units for indications and contraindications, preparation, procedure, and complications. Then when you click the first one, a thumbnail comes up. This is the word we developed on Storyline, and it is embedded in my courses. Buttons are used as triggers to proceed the module, and animations and the other graphics are also embedded. This is about tension pneumothorax. When you hover over the figure, it shows the feature pathology of that condition. Lastly, I show you quizzes. This is a quiz to match relevant items. When you submit a correct answer, feedback is coming. Even when you fail, you can try it again. Next quiz is a multiple answer question. You need to choose all the correct answers. This is only one part of the e-learning, but I hope you understand what it is like. Considering EDI, we still leave implementation and evaluation. Actually, we already conducted a study in October, providing this material prior to the hands-on training and evaluating their knowledge, performance, and the usability of the model. Now we are analyzing the data, so I hope I could show the result of the study next time. To wrap up, by applying this area of instructional design, we developed an e-learning model for surgical procedure, chest tube insertion. We applied this in a blended learning environment in preparation for a live simulation session. This is the acknowledgement. I appreciate the help of all of them. That's all for today. Thank you for your attention.
So now I stop sharing. So sorry for the earlier technological problem.
Junko, that's really wonderful. Any questions to Junko?
Hi, Junko. That was a really interesting thing. I know Articulate, it's about 20 years old software, and this procedure, especially for the pneumothorax, it's a really three-dimensional procedure. It's really critical to really see in 3D the whole thing. And I
Exactly.
noticed that most of the videos are basically just 2D morphings from one status A to status B, but it doesn't give you the depth of and the rotational possibilities of that. And have you thought about of how to implement that into LTMS, into the learning content management system with 3D elements that are actually interactive? And as a corollary of that, how, when it goes wrong, how you can define parameters using, for example, a haptic device to see, okay, I went too far or I didn't went too far. A haptic device is a device that basically will give you feedback on the depth perception that can be then be projected with an augmented reality type of projector, whatever. Have you thought of doing that? Because I think it's really interesting, and I think it will be really applicable to this case. Thank you very much.
Thank you for your great question, and it's a very important point. So at this moment, we haven't considered to implement 3D description into this model because I was not an expert of IT, so that was what I could at this moment. But with your advice, I wanted to try to use 3D technologies into the next phase. And regarding the depth of the tube and how deeply the resident will insert the tube is because this is a part of blended learning. So the resident will experience hands-on in-person practice after this e-learning. So so in that meaning, they can experience the depth of it's on mannequin, but your idea is great, and I know some platform can accept the 3D like STL files or something. So I will consider about it. So maybe it's gonna be a next step.
That's great. So
thank you very much.
Dr. Fried.
Junko, thank you for that excellent presentation. One of the things that you used to evaluate your educational intervention was usability. And usability, I think, is a very relevant topic to a lot of the people on this call, people in the innovation program, et cetera. Could you maybe talk a little bit about how you assess usability with respect to your educational module?
Thank you for your question. That's an interesting question. So there have been no standardized and no validated questionnaire for usability of e-learning or blended learning. So, but a colleague of mine published a scoping review of usability assessment in blended learning situation. So there he found 3 components in blended in usability. So they are effectiveness and efficiency and satisfaction. And he also developed a questionnaire covering all 3 components and validated, and now he's publishing it. So we borrowed the questions from questionnaire, and regarding each component, for example, for effectiveness, we asked if the content provided residents with new knowledge, and for efficiency, we asked if the content was easy enough to follow. Then lastly, for satisfaction, we asked if the resident enjoyed learning with that module. And each question is evaluated by 1 to 5 Likert scale. I hope I could answer to your question.
That's excellent. Thank you very much.
Thank you.
Perhaps I could ask a question now.
Yeah. Hi, Dr. Snell.
So thank you. That was great to actually see visually what you're doing. I'm wondering why you chose to use the ADDIE model. There's nothing the matter with it, but there are many models for curriculum design. And I don't know whether it's because it works better with simulation as a part of the blended learning, or whether you had any other reasons for using ADDIE.
So why I chose ADDIE model is I find the ADDIE model is frequently used in instruction design, and instruction design is kind of ubiquitous to develop curriculum and many types of instruction, not only for surgical hands-on training, but like all kinds of programs. And it can be a basis of design. So that's why I chose it.
Any other questions? So Junko, wonderful talk. Really appreciate your presentation. So there's a poll in the chat for Junko. Remember, the trainees, at the end, we offer them awards. So don't forget to fill in the poll. So wonderful. Thank you very much. So
Thank you.
Thank you. So it is a pleasure for me to introduce my dear friend for many years, Dr. Ann Marie Muffet. And I remember when I first met Dr. Malfait at the ORS several years ago. She was an invited keynote speaker. And I remember how packed the room was. So the room was so packed that we had to stand up throughout a really wonderful talk. So she's world-renowned scientist on pain and a much sought after speaker. And it's really a pleasure to have her. So we used to meet several times a year at the skeletal biology structure and regeneration NIH study section, and also as faculty for the US Bone and Joint Young Investigator Initiative. And I remember years ago visiting Rush University and see her state-of-the-art equipment in her lab, which was really impeccable. So Dr. Ann Marie Muffet is a professor of medicine and the George Stuppy, MD, chair of arthritis at Rush University in Chicago. She received her MD degree in 1989 and her PhD in 1994 from Ghent University in Belgium. So her early training was in rheumatology, and her basic research training focused on cartilage metabolism in osteoarthritis. So during her postdoctoral training, which was done at the Kennedy Institute of Rheumatology in London, UK, she studied the role of cytokines in inflammatory arthritis, and that was in 2001. Then she joined the pharmaceutical giant Pfizer as part of a team for the discovery and development of disease-modifying osteoarthritis drugs. In 2009, she established a research group at Rush University in order to study the relationship between joint damage and the neurobiological processes that underlie osteoarthritis pain. And her focus was, she had really these elegant animal models of osteoarthritis. Now, her lab has been continuously funded by NIH, and currently she consists of a group of about 14 scientists at different levels of their careers. And the long-term goal is to develop safe and efficacious treatment for painful rheumatic diseases with a focus on osteoarthritis. Dr. Malfait has contributed more than 100 research papers and book chapters to the literature. So she's published in really top journals, and I remember PNAS, some of really wonderful papers that she's contributed to the literature. So she's been associate editor for osteoarthritis and cartilage, and for arthritis and rheumatology since 2013. and she just ended her term on the board of directors of the Osteoarthritis Research Society International, as well as the Rheumatology Research Foundation, and her term as chair of the Committee on Research of the American College of Rheumatology. So she serves on the Scientific Advisory Board of the Arthritis National Research Foundation, and she feels passionate about osteoarthritis and pain. As faculty of the US-born and joint Young Investigator Initiative, she is strongly committed to motivating young researchers to join the efforts to study this very common disease that is rapidly becoming one of the major unmet medical needs in the world. So, Dr. Muffet, it's a great pleasure, and we welcome you, and I look forward to your talk. So it's all yours.
Thank you, Fax, and then thank you everybody for the invitation to speak to you about apparently what I'm passionate about, which is pain in osteoarthritis. And so I am speaking to you from my office in Chicago. My office is here, right here. I'm sitting right under this roof, down below there, overlooking the Chicago skyline. And so these are my disclosures. So I will be talking about osteoarthritis, as you just heard. And for those of you who do not know, osteoarthritis is considered very boring. So already in 1888, this doctor in Bath in England said that few things are so apt to cause a drowsy despair at a medical meeting as the prospect of an academic discussion on osteoarthritis, because the field is so barren and the harvest is so small. And that is 140 years almost ago. So unfortunately, the field is still actually quite barren, and we have not had any harvests until now. And so I always say, even if you're bored, please do pay attention here and there, because other body parts may preoccupy younger men, but by middle age, men have their knees on their mind. And so why is that? Well, that is because osteoarthritis is actually one of the leading causes of disability and chronic pain everywhere in the world. More than 300 million people in the world have osteoarthritis. Year after year, the WHO says that osteoarthritis is the third most rapidly rising condition associated with disability, only behind diabetes and dementia. And that's partially because of the overall aging of the population, as well as the increase in obesity, which are major risk factors for osteoarthritis. It's the #1 reason for knee replacement, and there are no effective therapies to date. So the FDA or any other agencies have never approved disease-modifying drugs for osteoarthritis. Analgesics have weak to moderate effects. They have to be used chronically, and that often comes with substantive side effects, especially in an older population. Osteoarthritis most commonly affects the knees, as well as the hips, as well as the small joints, the joints in the fingers, and the small joints in the spine. So it's a very, very common disease. And I will not talk too much about the pathology since we are focusing on pain here, but to describe in epidemiological studies, to describe osteoarthritis, people use a radiographic definition. And this is what it looks like on an X-ray. There is joint space narrowing because the cartilage has eroded away. There's subchondral bone sclerosis, and there are bony spurs, bone remodeling osteophytes that form at the joint margins. And here you can see cartilage degradation really is a hallmark of osteoarthritis. And we think of osteoarthritis as the failure of the joint as an organ. And for patients, this is what osteoarthritis is. It's pain and it's disability. Now, it's quite well described, and it has been described for a long time, that when we use the radiographic definition of osteoarthritis, that there is not always a perfect overlap with pain. So there are people who have knee pain, but an okay looking X-ray, and there are people with a really bad X-ray who actually do not have pain. So there is this disconnect between the two. And so this is really what we are studying in the lab. What is the relationship between joint damage and pain? Why is it that a knee with osteoarthritis hurts? And how does joint damage cause pain, if it does? So again, if we look a bit in more detail at osteoarthritis as a pathology, then the X-ray in the knee here that I showed you really is the end stage of what is often a very long progression of structural damage in the joint. And this can be decades actually before we get there. Before that, there are a lot of other things that are happening in the joint, often in the soft tissues, that can nowadays be detected by MRI, and MRI will detect things like effusions, synovitis, as well as bone marrow lesions. But early on, there are many things that are happening in the different tissues in the joint. There can be synovitis, there are molecular changes in the cartilage, and there are changes in the subchondral bone. And so this is really a matter of years, and the way this progresses exactly can be determined by mechanical factors such as joint alignment, genetic factors, as well as systemic factors such as obesity or menopause. So that's the damage in the joint. So what happens to the pain? And it's only really in about the past 15 years or so that people have very carefully started to document how pain progresses in osteoarthritis. Now, typically, the pain in osteoarthritis has an insidious onset. So people will say that they have flares of pain and then long pain-free episodes. And very typical, this pain is activity related. So they will say that it will hurt when they go up the stairs, for example, and then the pain will go away when they have rest. There's a very strong mechanical component to osteoarthritis pain, and I will get back to that. Now, the pain can also radiate outside the joint, and as the disease progresses, the pain can become more persistent. And in really severe osteoarthritis, there can also be pain at rest. People will tell you that they wake up in the middle of the night with severe flares of pain. And then in more recent years, and I will talk about that a bit later on also, is that that people have documented actually that there are many neurosensory changes that accompany the osteoarthritis pathology, such as lowered pain pressure thresholds. There are changes in proprioception. There are neuropathic elements to the pain, such as burning or tingling. And again, I will come back to this. And so here again, the way this all progresses can be determined by mechanical factors, genetic factors, and systemic factors, such as menopause or obesity. And so really, again, what we are trying to study using mouse models, as you just heard from Dr. Mwale, is that what is the relationship between these different aspects of the disease? So first, let's talk a little bit about the basic anatomy of pain and joint pain. So pain is essentially detected, painful signals are detected by specialized pain-sensing neurons called nociceptors, and these innervate peripheral tissues, in this case, the joint. And so the cell bodies of these nociceptors are located in the dorsal root ganglia. And so these cells are unique, what's called pseudo-unipolar cells. So they have a cell body with a stalk that splits in two. There's a long peripheral terminal that goes and innervates the peripheral tissues. And then there is a shorter central terminal that goes into the dorsal horn of the spinal cord, where the first synapse occurs. And from there, the signal is then relayed to the higher, to the midbrain and the higher regions of the brain. So that's the basic template of pain. Now, what happens is that when something really happens, like an inflammation or a tissue injury or more prolonged noxious stimuli that are affecting the body, then this basic template becomes amplified. And this can happen at the peripheral level, and this is called peripheral sensitization. And what that means is now that this system sort of goes on high alert, and something that triggers and activates the nociceptors nociceptor here and triggers an action potential is now actually felt too fast, so that something that shouldn't hurt, just like touching, just as when you have a wound or a burn, when you just touch the skin, then action potentials are being fired. And so that is called allodynia. It's a non-noxious stimulus that is perceived as painful, or something, just a light slap might be really, really painful. That's called hyperalgesia. So a high alert to pain. This happens at the peripheral level. There are also very many pathways and processes in the central nervous system that contribute to what is called central sensitization. Now, there are different classifications and classes of pain that people and the International Association for the Study of Pain recognizes. There is nociceptive pain, which is sort of the basic template, adaptive pain that I told you about. So when nociceptors feel a painful stimulus and relay that inflammation. Inflammatory pain is when this now is augmented in the presence of an inflammation and inflammatory mediators to cause these different types of sensitization. Neuropathic pain means that something has really happened to the nerves themselves, such as, for example, a virus infection, a herpes, for example, or chemotherapy or diabetes. And then there's also nociplastic pain. That is really, it's a category that means, we don't know what's going on. There are no obvious inflammation or changes to the nervous system that could cause this. Now, when we think about, say, knee pain, we should really keep in mind that all these different classes of pain and processes may be going on at once. So it becomes a complex thing. And then on top of that, there are these very many things that make us human that actually contribute with the pain and that can further determine whether a pain will become chronic. And there is catastrophizing, there is anxiety, there is depression, there are sleep problems that really all can accompany chronic pain, or that can further modify chronic pain. And on top of that, there is a lot of recent research now ongoing that really shows that there is a very pronounced sexual dimorphism in the way pain is perceived. Not only that, but that really pain is handled at a very basic level between men and women. So this paints a very complex picture. So one says, how could we really start studying something as complex in a mouse? Now, in the case of osteoarthritis, the good news is actually that the clinical evidence is there that the osteoarthritis pain has a very strong peripheral drive. And this clinical evidence is listed on this slide. So first of all, intra-articularly administered local anesthetics injected into the joint can alleviate pain. Secondly, in the vast majority of cases, but not all of them, but in the vast majority of cases, a total joint replacement will actually offer pain relief. Thirdly, antibodies that neutralize the peripherally active nerve growth factor, which is a very strong pain mediator, shows pronounced analgesic effects in patients with osteoarthritis. So, and they do not enter the central nervous system. And then lastly, in addition, whereas there is this discordance between radiographic findings and pain, we now know that specific joint pathology as detected by MRI, such as bone marrow lesions and synovitis, have been clearly associated with pain. So this is the clinical evidence that there is a strong peripheral drive. And so today I will actually focus on the periphery only. So the model that we use mainly is a model that some of you may be familiar with. It's called a destabilization of the medial meniscus. We do it in a mouse. And what we are doing in this model is we cut this ligament here, which is the medial meniscotibial ligament. And what that does is that it actually stabilizes the medial meniscus. And when we cut this ligament, what we introduce is a very, very slight instability in the knee. Unlike, for example, when you actually cut the medial meniscus, which is a much more severe insult to the knee. But by using this very slight insult and this slight instability, we actually can induce an osteoarthritis that is remarkably slowly progressive in a mouse knee. So you can see here the cartilage degeneration we actually monitor routinely for 16 weeks, so 4 months after surgery. So here you can see this is an intact medial compartment. And so we can see by 4 weeks, there's almost nothing to see. By 8 weeks still, the cartilage is mostly intact. There's subchondral bone sclerosis. It's not until week 16 that we see that this actually becomes a real aggressive joint damage. And that's very unique to this model. Other models of osteoarthritis are much faster progressing. If you cut a meniscus in a mouse, within 3 to 6 weeks, there's really a severely damaged knee. So here we can use this slowly progressive model to assess different pain-related behaviors. And some of those that are listed there on the slide. So I'm not going to go into any detail here, but so we have developed a whole battery of behaviors that we can assess in mice to see if these mice have changes to their sensitization, to their pain, to their mobility, locomotion, proprioception. And I will just give you a few examples here in the next slide. So, for example, if you look on the left, we can measure secondary allodynia in the hind paw. So we do the surgery in the right knee, and then we can use these von Frey fibers to look at the withdrawal threshold in the paw, in the plantar surface of the paw. And so you can see that a mouse after DMM surgery by week 4 has severe allodynia. So this is just a fiber that is being used, and the mouse withdraws its paw. And this is maintained for 16 weeks. Sham-operated mice do not actually get this. So this shows that these mice have sensitization to a mechanical stimulus, and it happens very early. Another example here is that these mice develop weight-bearing deficits. So this just looks at how much weight does the mouse put on its operated paw, on the right paw, compared to the left paw. So there's a little dip right after surgery, but then it actually for 8 weeks normalizes. But then you can see that the mice with the DMM surgery only by 8 weeks start favoring the non-operated leg, and they are no longer putting weight, indicating that this is likely a pain-driven behavior. So this is just an example, but there are many different types of behaviors, and what we are seeing is that they all develop in a time-dependent manner, and importantly, the response to intervention is time-dependent. Now, what I want to focus in that is that, as I've already mentioned, that osteoarthritis pain is essentially mechanical in nature. And that is something that we can use to understand what the underlying neurobiology of it is. So this here shows a test that we developed to measure knee hyperalgesia in the operated knee. So knee hyperalgesia, we just put this little force transducer on, and in a blinded manner, we can squeeze the knee, and the operator is always blinded, and we can see how much force can we put on the knee. And you see in a healthy mouse, that's about 450 grams. And in mice after sham or DMM surgery, by 2 weeks after surgery, this goes down to about 250 or 300 grams. So the mouse will withdraw its knee. It doesn't like it. But then little by little over time, this goes back to baseline. And you can see that in the mice with osteoarthritis compared to the sham operation, where we open the entire knee, we just do not cut the little ligament, so there's no destabilization. There is always less knee hyperalgesia. So the deeper you go, the more pain there is. So the knee hyperalgesia is a real a form of mechanical hyperalgesia. We can actually turn this around with morphine. This is a vehicle-controlled experiment. So that is indicative of the fact that this is actually a pain-driven behavior. And what's really important, and I'll get back to that, is that when we inject lidocaine intra-articularly compared to vehicle, again in a blinded fashion, that we can actually reverse this mechanical allodynia. What that is telling us is that this mechanical behavior is actually mediated by intra-articular nociceptors. And again, I will come back to that in a minute. So this knee hyperalgesia really is indicative of mechanical sensitization, and we can use this behavior now to start identifying peripheral pathways that lead to this mechanical sensitization in osteoarthritis. So what happens is when nociceptors innervate different tissues in the joint, they can be sensitized and activated by algogenic molecules in the joints, such as nerve growth factors, cytokines, chemokines. There can be fragments from the cartilage. So disease-associated molecular patterns that bind these nociceptors and sensitize them. And so we have now developed a technique to visualize nociceptor sensitization in response to a stimuli. And that is what I will show you next. So what we are doing here is we are using in vivo calcium imaging as a tool to visualize this sensitization. So what you see here is a live mouse, it's anesthetized, and we can actually expose the dorsal root ganglion. And this is, in this case, is the DRG4, can be 3 or 4. That's where the cell bodies are that come from the nerves that come from the knee. And so this mouse is alive. And what these mice are is that these mice actually express a genetically encoded calcium indicator protein in their sensory neurons. And so this indicator protein increases its fluorescence intensity when it binds to intracellular calcium. So it's a surrogate marker for activation. And so in a minute, you will see how we do this. We can take this force transducer, just as we did to measure the withdrawal threshold, and we can then put force either on the paw or on the knee, and we can see what happens in the dorsal root ganglia. And that's what I will show you next. So here is the L4 dorsal root ganglion of a sham operated mouse, and we pinching the knee of this mouse. And so what you're seeing there is that a few of the cell bodies that are coming from the knee are activating. So I'll show it again. There's just a few cells that are activated when we pinch the knee, which is a normal response. Now here, this is what happens after DMM surgery. So I guess you could see this very clearly that this really is a much more pronounced response, actually. And we can also now quantify this, and so we can also measure responses to other things. But clearly, after DMM surgery, there are more neurons that are responding. And so we are trying to identify exactly and characterize exactly what are these nerves that are responding, because the ones that respond after sham surgery arguably are the ones that you want to preserve. They are the ones that are sensing pain, as opposed to these extra neurons that are recruited after DMM surgery, which are really mediating the pathological pain associated with osteoarthritis. So we are trying to identify these nerves, mechanisms of sensitization, and where exactly are they in the joint. And I'll get back to that. But first, I want to go a little bit back to the human situation, because you could say, and I'm guessing many or some of you are surgeons, well, okay, these are mice, fine. So we can see knee hyperalgesia, we can see mechanical allodynia. Is that really relevant for patients with osteoarthritis? Well, it is. So in the last 15 years, there have been really massive studies where people do so-called quantitative sensory testing on patients with osteoarthritis. And they use the exact same tools as we do. They use these von Frey fibers as well as little force transducers. And so what they are finding is that indeed, osteoarthritis patients have signs of nervous system sensitization. They have lower pain thresholds at the joint, but actually also away from the joint. Sensitization measures have been associated with osteoarthritis knee pain severity. What is, I think, really quite striking is that joint replacement is not only associated with reversal of pain, but in most people also with reversal of sensitization. And then lastly, there are currently studies emerging that that really indicate that this pressure pain sensitivity at the knee may occur in patients before actually knee pain occurs, and that is actually a major risk factor for developing persistent knee pain 2 years later. So this is in patients with osteoarthritis. Okay, so now I'll go back into the mouse, because one of the questions that we are spending a lot of time on is, well, if these nerves here in the joints are actually sensitized, we would really like to know exactly where these nerves are. Now, why is that so important? Because the sensory innervation of the joint has actually not been that well described in osteoarthritis. So it's been long known that there are many nociceptors in the joint. So the knee joint is highly innervated by sensory nerves as well as by sympathetic nerves. There's a lot of work there out of Canada, actually. Jason McDougall, and before that out of Germany. In rats and cats, nociceptors make up to 80% of all knee joint afferents, really telling us that pain sensation must be very important for the integrity of the knee. Nociceptive-free nerve endings have been found in the capsules, in the ligaments, even in the menisci, in the periosteum, and in the subchondral bone, while cartilage is considered aneural. Now, in order to really describe this, where free nerve endings are in a joint with osteoarthritis, we developed these, what we call NAV 1.8 tomato reporter mice. And so what these mice are is, they are mice where we have inserted a bright red fluorescent tomato reporter using a NAV 1.8 Cre system. And so NAV 1.8 Cre essentially marks all nociceptors. It's a voltage-gated sodium channel that is expressed by more than 90% of C fiber nociceptors and many A delta fibers. It's critical to generate action potentials. And these are typically all small to medium-sized neurons. So if we actually look now at these mice and we go look at the dorsal root ganglion, so you can really see these red cell bodies here, small and medium-sized, those are nociceptors. So here we can look at the nerve fibers. So you can see that you can trace the nerve fibers. You can also see them beautifully enter the dorsal horn of the spinal cord here. So this is really a very powerful tool to sensitively go look at where are free nerve endings in mice. And so we use this in mice with arthritis. This is a healthy mouse joint. So we focus on the medial compartment because that's where osteoarthritis develops mostly, just like in human. And so what you see is actually a lot of nociceptors. These are older images. In the beginning, they weren't all that pretty, but you will see that they get better over time, is that there are nociceptors in the bone marrow. We see some in the periosteum. Apart from that, it's actually pretty uneventful. But what happened really surprised us after a DMM surgery. In this case, this is 16 weeks after DMM surgery. So this is the medial compartment. You can see there's a lot of osteoarthritis there. There are osteophytes, cartilage degradation, subchondral bone sclerosis, some synovial thickening. And what we are seeing is that in the synovium, we see new nerves that are sprouting. And we also actually see some in the medial meniscus. And this has been, we've now been doing this for several years, and this is highly reproducible. So this is a sham surgery. We can quantify this. And so we really see by 16 weeks after surgery, a sprouting of new nociceptors in the medial synovium, as well as in the medial meniscus. What's more, actually, is that when we look into the subchondral bone, we see the subchondral bone sclerosis. We see that in the sclerotic bone, there are channels. In these channels is blood and blood vessels, but we also see in these channels, we see what looks like nerves, nociceptors. And again, we can quantify this. So this is really very pronounced 16 weeks after surgery. Channels in the subchondral bone that contain nociceptors. Now, again, you may ask, well, what about humans? in humans, actually, this had been reported anecdotally up until a few years ago in knees with osteoarthritis by the group of David Walsh in England, that there are these osteochondral channels that actually come from the subchondral bone and go into the cartilage. The cartilage in humans is much thicker than in mice. And so there are these bones, there are these osteochondral channels where they actually found sensory neurons and blood vessels. And more recently, they have done work where they really try to quantify this. And here they have done staining for CGRP to detect nerves in these channels. And they have actually found that there are CGRP positive fibers that are in the subchondral bone in patients with osteoarthritis that are correlated with pain. And this looks remarkably similar to what's happening in the DMM model. So this is our work in the DMM model. We just try to emulate this and see what would happen if we stained with CGRP. And so again, in the subchondral bone in mouse knees after DMM, we see these CGRP positive nerves in these subchondral bone channels. So the structural neuroplasticity really appears to be part of the pathology of osteoarthritis. So again, here I'm showing you an example 8 weeks after DMM surgery, where we see nerves in the synovium, as well as these channels in the subchondral bone. So we were curious, these are all newer data, where we looked at different other models. For example, we did a partial meniscectomy, which is a much more severe model in mice. And here too, we found sprouting in the medial synovium, as well as these very clear channels with nerves in the channels. We have done a couple of mice in collaboration with Dr. Tristan Martz at the University of Michigan. He has a closed model where he does an ACL rupture by doing an impact on the knee. And 4 weeks after surgery, we see here too this sprouting of, so the controls don't have this, I didn't put this on there, but they have this medial synovium sprouting of nerves, as well as these very clear channels. And then very interestingly, because of the COVID lockdown, we actually had many mice in the lab that were sitting there and aged till the age of 2 years. And here we did a staining with PGP 9.5, which is a neuronal marker. And so these mice develop by age 2, they develop spontaneous osteoarthritis. And here too, we see this sprouting in the medial synovium, as well as these channels in the subchondral bone. So there is this clear neuronal plasticity that is going on in joints with osteoarthritis that seems to be very much part of the osteoarthritis pathology, in addition to cartilage degradation, bone remodeling, synovitis. We have to consider that neuroplasticity is part of osteoarthritis pathology. Now, I just want to make a little philosophical detour and thinking, why would that be? Well, when we talk again about pain, we really have to appreciate, so that's the ISP's definition. Pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. And so pain really serves a very vital role in the survival of the organism, because it prompts the avoidance of potentially dangerous situations, or when you've already harmed yourself, such as this boy here, then, you know, he will know that he should put a Band-Aid or something on that, or go clean it out. So it forces rest and immobilization, which helps the healing process. Now, if we go back to what's happening in a joint there in that case, so the same studies that I have already showed you, where the group of David Walsh, where they have found these subchondral bone channels with nerves in them in human joints with osteoarthritis, they also actually found that nerve growth factor in the synovium, as well as in these channels here, was associated again with pain. And if some of you are working in the field of osteoarthritis, and then you are very well aware of the recent interest, the past 10 years or so, that there has been in nerve growth factor. So joint innervation is not static, and we do not know what the role is of nerve growth factor, or what is the biological role of these nociceptors that are sprouting in the subchondral bone beyond pain. So we know that nerve growth factor is increased in the synovial fluid of patients with osteoarthritis, as well as in the different tissues. And nerve growth factor has been a target for osteoarthritis pain in the past decade. It was actually discovered in the 50s by these two people here, Dr. Levi Montalcini and Stanley Cohen at Washington University in St. Louis, because they found that it was an essential survival factor for subsets of neurons during embryonic development. And it was the first growth factor ever discovered, which earned them the Nobel Prize in 1986. Now, so nerve growth factor can bind either the TRIC-A receptor or the P75 receptor, but the pain pathway has been focusing on this binding the TRIC-A receptor. Now, for the past 10 to 15 years, many companies have made neutralizing antibodies that will actually sequester NGF, so it cannot bind to its receptors. And it had been anticipated that around this time, the anti-nerve growth factor antibodies, specifically the Eli Lilly Pfizer one, tanezumab, would have been approved for treating pain in osteoarthritis. There was very big excitement about this with very positive clinical trials. However, Eli Lilly Pfizer stopped their program just 2 weeks ago because there have been for years now important issues. There is one side effect in depending on the study, between 3 and 10% of people, but there's a side effect of rapidly progressive osteoarthritis in people. And this is really not understood. So it's a rapidly progressive osteoarthritis type 1 means that the progression of joint space narrowing on an X-ray is larger than 1 millimeter per year. But more importantly, there is also type 2, where there is really subchondral bone collapse and bone damage. And so people who were on tanezumab for pain in one index joint were actually at risk for accelerated symptomatic osteoarthritis in that joint or even in other joints. The mechanism is unknown. It led to increased need for total joint replacement in a subgroup of patients in the clinical trials. And so very unfortunately, but this program has been stopped. So let's have a little focus on nerve growth factor as a target for osteoarthritis pain. It's a very interesting molecule. Whenever there is tissue injury, cells will release nerve growth factor and it will bind its receptor on nociceptors. So what happens next is that the binding of NGF to TRIC-A increases the activity of a wide range of ion channels, such as voltage-gated sodium channels on the peripheral nerves, and that results in an immediate depolarization and a sensitization. But secondly, what can also happen is that this complex of NGF and TRIC-A will be retrogradally transported to the cell body in the dorsal root ganglion, and then will increase the transcription of genes that are mediating pain, such as, for example, CGRP or more ion channels, such as NaV1.8. And then thirdly, and that's more theoretical actually, is that potentially nerve growth factor can be pro-algesic through stimulating the sprouting of new nerves at an injured site. And this has been shown in models of bone fracture and bone cancer, as well as inflammation. This has never been shown actually in osteoarthritis, which is remarkable. But these are pilot data. But what we do know, we've also been doing some studies where we inject nerve growth factor intraarticularly in the joint of a healthy mouse. And what we are inducing is knee hyperalgesia and joint pain. You can see this here in the graph on the left. So as I said, these are pilot data, but this is again looking at knee hyperalgesia. So here is the baseline. And when we do repeated injections of nerve growth factor, these mice develop knee hyperalgesia. But importantly, these mice really start to grow. So you see here on the left is the control, and here's the synovium. You can't see any nerves. After 4 weeks, we really see a very strong sprouting of these nerves when we inject nerve growth factor. So these are not mice with osteoarthritis. They have just been receiving intraarticular nerve growth factor. We even see nerves sprouting in the subchondral bone. So this really recapitulates what we are seeing in the DMM model and also in other models now. So we are really trying to look at what is the role of NGF, and more importantly, what happens if you block nerve growth factor, because this will hopefully help us understand why this rapidly progressive osteoarthritis is occurring. I will skip this. Now, I just, for those of you who are interested, as a background, the group of Tom Clements at Johns Hopkins really has done some beautiful work in the past few years, looking at the potential role of neurons that express the receptor for NGF in bone homeostasis. And they have reported in the JCI a couple of years ago that you really need these nociceptors in order to repair a fractured bone. And so NGF TRK signaling may be very important in bone homeostasis. And so it may also be important in the homeostasis of subchondral bone. And this may be contributing to what is happening in joints with osteoarthritis. Now, that are treated with anti-nerve growth factor. All that to say that understanding the relationship between pain, neuronal remodeling, and the overall joint pathology will be expected to really clarify what's going on with anti-NGF and its effect on joint integrity. Okay, so now I can just quickly wrap up with some other thoughts on. So analgesia, really pain reduction, elimination, or prevention of pain is something that we are all very familiar with. But so in 1898 is when marketing began for the two big classes of analgesics that still exist. So Bayer started marketing this in the United States, both aspirin as well as heroin. And heroin, they actually marketed as a non-habit forming alternative to morphine in the same year. So, so these are the major drug classes for pain: opioids, NSAIDs, and cannabinoids. They're all derived from natural products. And then recently, for osteoarthritis pain and pain control, two new drug categories were added, so antidepressants and gabapentinoids. But it's interesting to actually consider that the analgesic effects of those drugs were discovered secondarily to their use for other illnesses, such as depression or epilepsy. There have been many attempts to tamper with morphine and make it less addictive and change it. But the bottom line is that there are actually no examples of drugs currently designed de novo ever for the treatment of human pain, which I think is kind of interesting. So chronic pain. So I will say this too. So when we try to further understand this and try to develop new targets, so we have to really look at everything that's going on in the pain pathway here. So again, I've already said it's a chronic progressive disease and all these things are happening in the joint, but there's a lot happening as well in the nervous system at the same time. So using the DMM model, we have actually found that the dorsal root ganglia over time get invaded with macrophages. And we also know that over time, the synapse here at the dorsal horn starts being modified by microglia, and we see microglia activation 16 weeks after surgery and not earlier in this model. We also see that there are a lot of transcriptional changes going on in the dorsal root ganglion. The NGF is expressed there, but that's just one example out of many genes. In fact, we have done a microarray analysis, and we have, for example, we see that there are many genes here that are regulated after DMM surgery that pertain to pathways of neuroinflammation and pattern recognition receptors. So a lot going on in these cell bodies of these nerves. And so potentially all these different pathways here could be targeted. Now, Faxon, I do not know until when I have, because I started off the hour. I have just a few more slides left, but I could also stop. Mm-hmm.
No, just continue.
So I just give you one example on how we can actually look at this to identify new targets in this pathway and in the pain pathway at the level of the nervous system. So neurons, they can express a whole host of receptors and ion channels that are pharmacologically targetable. And so, but we actually do not know very much on exactly what is expressed when in the course of osteoarthritis. So we are using not just targeted approaches, but what I want to give you an example about is we are using large-scale phenotyping approaches to try and identify new targets. So just by doing, for example, a single-cell RNA-seq after DMM surgery in the dorsal root ganglia, we can find all these different, we can really molecularly characterize all the different sensory neurons that are here, but we can also find, as I've already said, macrophages start invading the dorsal root ganglia. We can also find different immune cells in there. So this is opening up many possibilities. And so interestingly, just about over a year ago, the NIH published a list of what they called understudied druggable targets for pain. It was a list of 328 proteins, and they defined them as, well, there are very few publications and there are no grants on this, and they are druggable. So they're GPCRs, ion channels, or kinases. And so we looked at this list and we mapped it against our single-cell RNA-seq data. And so I will show you now what we found. I will skip this, but as an example, for example, we actually found of these 328 proteins that they put out there, the NIH, we found that about 70 of them were actually expressed in the DRG. And so if you look at, for example, a potential GPCR of interest would be GPR45, but that's very broadly expressed. So we're less interested in that. But if we look at something like the prokineticin receptor 1, we could see that it's very specifically expressed by specific subsets of neurons. In this case here, that's a non-peptidergic so-called MRGPRD neuron. And what's interesting about that is that somebody had already had a publication that this is a molecule potentially related to pain, but we got excited about that because this specific subset of nociceptors, these MRGPRD nociceptors, had been published on to say that they are really mechanosensitive nociceptors. And so then we actually developed a reporter mouse, and lo and behold, we found that these nociceptors are sprouting in these subchondral bone channels, which is really interesting. We do not see them sprout in the synovium. Anyway, I've also already said that there is an influx of macrophages in the dorsal root ganglia. So we're also looking at specific GPCRs that are expressed by macrophages. And we found one called GPR34. And what that has been implicated in one or two papers with chronic pain. And so what we are seeing here is that recently, we are actually using the partial meniscectomy model in mice that 12 weeks I'm sorry, that 12 weeks after surgery, we see this influx of macrophages in the dorsal root ganglia after PMX surgery in these mice with osteoarthritis. And so we've just developed RNA-scope to look at this here, and we can really see now how the red is the macrophage marker and the green is the GPR 34. We can see how this receptor is increased after PMX surgery. So this is just showing that just using this list that the NIH published as potential interesting targets that could be druggable, we see this now specifically activated in the course of experimental osteoarthritis. So this is something that we are trying to leverage to try and identify new targets and develop new drugs. So I will just summarize some takeaway messages here. The neuroanatomy and the functional nociceptive processing in an osteoarthritis joint are considerably different from a normal joint, and that's something that we really should keep in mind. It raises questions around the roles of neurons for pain, but also beyond pain for joint integrity. Neuroimmune interactions occur in the pain pathway, and they may contribute to the genesis of pain. And so obviously these observations provide a potential avenue for identifying new and hopefully safer targets. And osteoarthritis pain and joint damage can only be properly understood by fully considering this neuroplasticity in the joint, I think. Now, I would just like to end that I'm very happy to announce that a few weeks ago, we were actually awarded a large grant, center grant from the NIAMS to establish a new center, the Chicago Center on Musculoskeletal Pain. This is its website under construction, and we hope to go live in about a month or so. And so those of you who are interested, we will be offering different resources, many of the techniques and many more that I have mentioned here to study pain, not just in osteoarthritis, but all types of arthritis, musculoskeletal pain. We will also have pilot grants that will hopefully be we will be able to also send outside the United States. We are trying to work on that with NIAMS, and we will also have other resources that may be useful to some of you for your research. The overall aim of this is that we really can expand the musculoskeletal research community and promote interdisciplinary research and provide people with access to all these different resources. And so with that, I would like to end. These are the different people in the lab who are currently contributing, and you know, I did nothing, they did all this work. And Dr. Rachel Miller is the co-PI of the lab, so we share a lab, and Dr. Richard Miller is not related to Rachel Miller, but he is our collaborator at Northwestern University. And thank you very much. And obviously, I would like to thank our funding sources.
That's absolutely wonderful, Ann Marie. Thank you very much for that exciting talk.
Should I stop sharing or, okay.
Yeah, you can stop sharing. So any questions?
Hello, Aunt Marie. I have a question. First of all, thank you. It was a very great and informative presentation, and congratulations for your center. So is the neuroplasticity is only due to NGF, or are there any other factors involved in it?
So there have to be other factors. So there is one, there is a group at Johns Hopkins by Dr. Zhao, and they are working on netrin derived from osteoclasts. So, and they have strong data to show that netrin in the subchondral bone specifically has an influence on axonal sprouting in the subchondral bone, and they use ACL an ACL transaction model, and I think they also have done it in a DMM model. Apart from that, I'm not aware of other things in the public domain, but axonal growth and is a complex thing. The reason why we focused on nerve growth factor is that nerve growth factor was up until a couple of weeks ago a big target in the field of osteoarthritis, and it's everywhere in the joint. I didn't discuss this, but cartilage expresses it after injury. Synovial macrophages express it. Different cells in the bone, maybe osteoblast express it very fast after injury. So it's sort of the most low-hanging fruit to look at, and it may be a master regulator, but that's a hypothesis for downstream molecules. But that's a hypothesis, yeah. Mm-hmm. That's one of the things that we want to study. Mm-hmm.
Okay, thank you. And other thing, like it's NGF give rise to other inflammasome as well, so expression or like IL-1 beta and TNF alpha, and if you suppress NGF, so is there any all the pathways will be suppressed or only the NGF?
We are looking at that. So yes, so NGF can be made by many cells and act on many cells. So the receptor TRK, for example, is not just expressed by nociceptors, but also by chondrocytes and by other cells, by mast cells. And I mean, it's a vast literature, and in the joint itself, very superficially looked at, but outside the joint, the literature is big. And so there are many complex relationships between the different cytokines. It's something that we're also trying to look at, and what's downstream of NGF, which cytokines are upstream and downstream of NGF. So I don't know the answer in the joint. And when you start looking in the literature, it's slightly a mess. So we are trying to study that. Mm-hmm. But it's a very good question. Mm-hmm. But there is no clear answer, actually. There isn't. So we are finding, for example, an interplay, and there's some literature on that, between toll-like receptor signaling and nerve growth factor signaling. That is, for example, one that we see. Mm-hmm.
Yeah.
Question. You have another question, Muskan?
Yeah, I have one. If you don't mind, can I ask?
Yeah, sure.
Yeah, sorry. So we are looking at the periphery, like periphery sensitization leads to central sensitization. So why is it so that the drugs which we used in OA are mostly affecting the central and not the peripheral? So because of which the pain keeps on increasing, so what's the basic thing we look while targeting for drug intervention?
Like duloxetine, and so you are right. That's what you're referring to, right? So that they are centrally active, and so the reality currently is that, and even prostaglandin inhibitors is that there. So, and I stayed away from central sensitization here because and from all the central mechanisms, because that's pain, and so once there's chronic pain, there are many targets to go after chronic pain, whatever the chronic pain is coming from, and that's probably very translationally relevant for the vast majority of people. What I'm trying to get at here is that, and likely earlier in the disease, that the peripheral stimulus matters, right? And that we probably have a big opportunity to go after real peripheral mechanisms that feed into that central. So so the way a peripheral stimulus, so to speak, hits the dorsal horn, and the DRG in between, there is a sort of gatekeeper in my mind that modifies the way that signal hits the dorsal horn, and then it all goes up. And then, people with chronic pain have a lot of overlap in the way the changes are happening in the brain, although not 100%, which I always find interesting, that people can do functional MRI in the brain and still sort of understand whether this was more OA driven versus something else. I always think that's really interesting. But that's why I focus on the periphery. I think, does that answer your question? I wasn't quite sure what your question was.
Yeah, it mostly answered it. Like periphery is something you should target first, then the central.
Probably, and I think there is a very big opportunity there, A, to early, but B, I also think in the periphery is where, and that I think was previously maybe less appreciated, is that the nerves are probably not just there for the pain, that they're really part of this pathology. And maybe that's a way forward for us to go after something, because people now, the definition of a DMOD, and we still don't have disease modifying drugs, is that they also have to do something about the pain. So if we want to really go after that, I think we will have to go after the periphery. Mm-hmm.
Yeah, thanks a lot. Thank you for answering.
Thank you for your questions. Mm-hmm.
Yeah, thanks, Muskan, for those wonderful questions. Ann Marie, you have some studies that you showed that in order for persistence of pain, you need the MCP1 CCR2 pathway. So, because I like your model, you can follow it longitudinally, temporal spatial, and you can look at the peripheral, and you didn't talk about the central nervous system, but you're right, because that's the gateway there. So have you tried to use an antagonist to, let's say, something like a CCR2 antagonist?
Yeah, we have. I actually left at that because I had too much, but yes, and it's interesting. So again, we actually just published a paper where we found, so CCR2, the receptor for MCP1, is expressed in the nervous system, but obviously that's a receptor that's expressed in many cells too. So it's expressed peripherally in the nervous system. We just published a paper actually where we saw that those free nerve endings that are sprouting in the synovium and in the subchondral bone express the receptor CCR2. And so we can inject, say, into the knee CCL2, MCP1, and induce knee hyperalgesia. And that doesn't occur in CCR2 knockout mice. But we are not the only ones who have tried to block pain with a CCR2 receptor antagonist. So we can do a one-off, we can do it intra-articularly. We just published that too, and block knee hyperalgesia. So say a mouse 4 or 8 weeks after DMM surgery has knee hyperalgesia, we inject CCR2 receptor antagonist in the knee, it immediately reverses. But there is very interesting work. We haven't done chronic administration, because very interesting, if Lara Longobardi at the University of North Carolina has published that she gave CCR2 chronically, receptor antagonist chronically, and she found that it really mattered when you block. So that's the temporal aspect, which I think is fascinating. So she had the best results if she blocked somewhere between week 4 and week 8. But no results if she blocked completely preventatively or completely late. Which just tells you, especially with these targets that are widely expressed, not just by neurons, but also by immune cells, that you probably have to be very careful, which is the same actually with nerve growth factor or with any of those. Mm-hmm.
Right.
So to me, this is why, in case that wasn't clear, and because I had to go a bit fast, but when we do the single cell RNA-seq and we look at different subsets of neurons, instead of just indiscriminately start blocking all neurons like you do with lidocaine or with anti-nerve growth factor or so. You can really, we are hoping that there are paths forwards where we can look after specific subsets of neurons that express specific receptors that we could then really target in a very targeted fashion, as opposed to something that blankets not just all neurons, but potentially also a whole host of immune cells. You know what I'm trying to say?
Yeah.
That illustrates that. And that's a little bit why we have stepped back a bit from CCR2 receptor antagonists and all that. Mm-hmm.
So in the study that you talked about, the clinical trial for NGF blockade, one of the other things that was interesting was that the patients that were taking NSAIDs fared even worse.
Yes.
So it would be interesting. I know it's quite complex, but in your mouse models, as you are doing with NGF, which was really fabulous, the results are really wonderful.
When you inject the NGF, it's amazing, right? The sprouting of the pain. Mm-hmm.
Yeah.
So the prostaglandin, yeah. So again, also the only group who has currently looked at that at a basic level is also Zhu Zhao at Johns Hopkins, the same papers where they looked at the netrin, and they looked the same what Muskan asked. So is that they actually looked at potential, again, bone pathways with prostaglandins. So prostaglandins are also important for the integrity of the subchondral bone. So there's this interplay between the TRK signaling and the prostaglandin signaling in bone integrity. So that is what we are now trying to do, is we are trying to knock out TRK selectively from neuronal cells, but also from non-neuronal cells, as well as knocking out NGF selectively from different cells, and see how we can look at the interplays of these different molecules in the subchondral bone, and how that affects not just pain, but the joint integrity itself. Mm-hmm.
That's wonderful.
There's only one paper on that, and that's Zhu Zhao from Hopkins on the prostaglandin relationship, and it also immediately pinpoints to the subchondral bone, which is interesting because that's what was happening in the patients. It was a subchondral bone collapse. Mm-hmm.
Right. Any other questions? Please just unmute and fire questions.
I see Dr. Gauri is on the line. I have met you before, haven't I?
Oh, Raul, yes, you have met him. He was in Pennsylvania.
Yeah, I met you at the University of Pennsylvania, exactly. Mm-hmm.
Yeah. So if there are no more questions, I would like to thank Dr. Muffet, and congratulations for that big grant. Really wonderful. And
so hopefully if somebody needs something, I don't know what all of you are working on, but it may be of use for some of you. Mm-hmm.
Yeah.
Thanks. Thank you for having me. Mm-hmm.
Thank you very much. And thank you everyone for attending this wonderful seminar. Thank you.
Bye-bye.
Bye.